Okay, welcome and good morning. I am Sarah Murray. I'm an associate professor in the Johns Hopkins School of Public Health in the Center of Global Mental Health. And I have the really distinct pleasure this morning of getting to welcome you to a day of getting to come together in community and think about some of the big problems and challenges and opportunities we have when it comes to addressing adolescent mental health. I want to invite you all to turn off your cell phones, or at least put them on silent, to close down your email if you can, and take a big breath to be present together. And I am thrilled to get to introduce Dr. Pamela Collins, professor in the Department of Mental Health at Johns Hopkins University, director of our Center of Global Mental Health, and commissioner on the Second Lancet Commission on Adolescent Health and Wellbeing. And so I will turn it over to her to welcome us to today's events.
Thank you, Sarah. Well, I want to introduce myself as a former adolescent. And as Sarah said, and many of you are former adolescents, and I think some of you are still in that range up to 24, and young adults beyond 24, but maybe less than 35. So welcome to everyone. As Sarah said, our goal here is to create a community of listening, of talking, of sharing ideas, and coming together to figure out where there are gaps in our solutions. How do we solve those gaps? So take advantage of the time to think, the time to meet new people, the time to network. In our online community, we want you to feel just as welcome to this time. So without further ado, I'm going to invite Sarah back to the microphone, and we'll get started with our first panel. And let's invite Dr. Augustina Mensa-Kwao to the stage as well.
We'll have Dr. T. Lovely.
In progress.
Okay. One second.
I'm sorry, I could no longer hear. Can you hear me?
Sabine, you can go ahead and start.
Now I can hear you. Okay, I can start. Okay, thank you. And sorry, I could not hear you speak, but now it's great. I hope you can hear me. So I'm very sorry that I really couldn't be at the Johns Hopkins Bloomberg School of Public Health in the US in person, but I'm delighted to speak at this local launch of our second Adolescent Health Commission in the US, with a particular focus on mental health in young people. This commission had its global launch in May this year at the World Health Assembly, with Dr. Tedros in attendance. underlining the great importance of this particular age group in global health discussions. And many thanks to our Commissioner, Pamela Collins, for making this local launch happen in the US as well. What I want to do first is explain what a Lancet Commission is and what we are trying to achieve with our commissions. Commissions are really large pieces of work. We define them as a scientific review, an inquiry, and a response to an urgent and perhaps neglected or understudied health issue. They are science-led and evidence-based. They consist of an international collaboration. They're multidisciplinary with people working together from different backgrounds. And ultimately, they aim for transformational change and are especially focused on policy or political action. When we start a commission, we outline 10 important steps to the commissioner group to explain what makes a great commission. Convene great people, we definitely had that at that commission, provide a critical review, develop a compelling story, offer original ideas or data, and write a startling message. Provide actionable conclusions, be forward-looking, inspiring, optimistic, and create an active afterlife. Give yourself time, but not too much. Usually these commissions take a minimum of 18 months to 2 years, sometimes longer. This particular one has taken a little longer. But why did we embark on adolescent health? I need to go back a few years as we started in this field by publishing a series on adolescent health in 2007, led by Susan Sawyer and George Patton, who sadly passed away in 2022, but he was still instrumental even for this new commission now. At that time, can you hear me?
Yes.
Yes, we can hear you.
You're good.
Okay, good. Sorry. So at that time in 2007, adolescent health was a fairly niche specialist topic, really. In the series, we aimed to bring specific areas of adolescent health to a broader audience. The papers then covered pubertal transitions in health, mental health of young people, adolescent substance use, and youth-friendly primary care services, or what we would call now adolescent responsive health care. We then had a second series in 2012, and that aimed to go beyond these specific areas of adolescent health and put adolescents in the center of health and development and take the first steps for those working in adolescent health to better engage with a wider global health community. That series argued strongly for preventive measures in adolescents, such as addressing tobacco and alcohol use, unhealthy diet, lack of physical activity, and this all to achieve a healthy development for adolescents themselves, their adult lives, and that of their children, what we now call the triple dividend. Fast forward now to 2016, when we published the first commission on adolescent health. One of the commission's central aims was to make adolescents the human face of the Sustainable Development Goals. It argued for adolescents to become active agents for change and encourage communities, including young people, countries and international organizations to act. Following this commission, a standing commission was created. And a standing commission means ongoing work in this area. In particular, aims were to expand the meaningful participation. A Lancet Youth Network was founded, develop the capacity of academics and advocates worldwide to maintain the visibility of and monitor progress in adolescent health, grow an evidence base for cost-effective actions to improve adolescent health that could be taken to scale at country and subnational levels, outline sustainable and scalable strategies for action through partnerships with other initiatives and sectors, and generate knowledge for action through new evidence designed to improve policies and programs around neglected aspects of adolescent health. Under this standing commission approach, a Lancet series on adolescent nutrition was published in 2021, analysis of future NCD risks and of injury disease burden and investment cases were published in 2022. So why did we need a second adolescent commission? We don't often do second commissions after a first one. The work of this second commission started in 2021, in the middle of the COVID pandemic. Its initial goal was to accelerate the implementation of the first commission's recommendations towards the SDGs and beyond. However, during the work of this commission, the world really changed dramatically. multiple new threats and challenges emerged. The pandemic's detrimental effects on the crucial phase of adolescence developing social contacts became apparent, and in particular also accelerated the mental health crisis among this age group. The climate crisis is accelerating, and climate anxiety has become a new dimension of mental ill health. Wars have taken place in Gaza and are still happening in Ukraine, Sudan, and the Democratic Republic of Congo, among other conflicts. Commercial influences continue to threaten adolescent health, with unabated advertising on unhealthy food, alcohol, and tobacco in traditional but also in new social media platforms. The digital environment is changing rapidly, with also detrimental effects on adolescent health and well-being. So what this commission's main aim is a call to action. Without concerted action now, the future of adolescence looks bleak. The recommendations are under the three main subheadings of creating enabling environments to transform adolescent health and well-being, amplify actions with existing systems, and develop innovative approaches to address complex and emerging health threats in partnership with adolescents. The Commission's work itself was a great partnership with young people. It had 10 youth commissioners. All work streams were co-led by senior commissioners and youth commissioners. 122 adolescents across the world were engaged in the youth solution labs, and a multidisciplinary group of adolescents acted as peer reviewers and of this commission, alongside more traditional normal peer review. So what next? We have multiple national launches. They have happened and are still planned. Sweden, for example, had a launch at the Karolinska Institute in early September, and the government of Sweden's website reported on the event and disseminated this report on its official site. There was a launch in China just last week that I attended, and I'm really excited that we now have this launch in the US as well. All these are led and facilitated by our commissioners, which is brilliant. What we've also embarked upon is the strengthening of an accountability mechanism by starting a countdown on adolescent health and well-being. This annual countdown will track and forecast progress in adolescent health and well-being using a set of indicators that were proposed in the Commission. These indicators cover topics under four broad headings: health outcomes, health risks, social determinants, and health and policy interventions. The specific indicators related to mental health are mental health and self-harm, DALYs, self-rated life satisfaction, and bullying. There are many that will have an indirect link, such as poverty or those not in education, employment, or training, for example. But it would be great for future expansion of these indicators to have a discussion of what we need to measure to track progress in this area in particular. So I hope that you will have discussions on this over the coming 2 days. These data on these indicators will be populated using global burden of disease data as well as other global data sets. And we'll also specifically comment on countries that have experienced the largest burden of ill health and have made little progress, as well as those countries where progress has been more substantial. With this, we hope to track progress and spur action. So let me conclude by thanking you all for attending this meeting and also those joining online. And once again, many thanks to Pamela Collins and her team involved in organising these 2 days. I hope you all will come away after today playing your part in thinking about a better future for adolescents. In other words, as an African proverb says, if you're not part of the solution, you're part of the problem. So thank you for listening, and I will now hand over, I believe, to Tina Mensa-Kwao, one of our youth commissioners, for a youth perspective on mental health.
I'm sorry, you're gonna have to tell me when to click for right now while we,
Well, we can shift to your computer if you want.
oh,
Do you have your presentation?
we can make the clicker work.
1 second, thank you. And thank you, Sabine, for that introduction to the commission.
Hello? Oh, 1 second, I'll call you.
All right, Tina, can you go ahead and try the clicker? Did you turn it on? Sorry, you're gonna have to tell me to click. I'm sorry.
Okay, sure. So you can click. All right. So as Sabine mentioned, what made this commission especially powerful was the role of young people. The Second Lancet Commission on Adolescent Health and Wellbeing really centered youth voices. Youth engagement was integrated across the commission from conceptualization to publication. And among the 44 experts, as Sabine mentioned, there were 10 youth commissioners recruited across the globe. The commission was intentional not only about including young people, but also about ensuring that young people led in decision-making. Next. As youth commissioners, we co-led work streams alongside senior commissioners, shaping every stage of the process. For instance, I co-led a work stream with Dr. Pamela Collins, examining how cities can be developmentally responsive to youth mental health needs. One commissioner, Shakira, she served as on the commission's steering committee, which is basically the leadership team guiding the report. And importantly, our involvement was recognized and compensated. And through this experience, I saw firsthand how meaningful youth engagement can deepen collective understanding and lead to outcomes shaped by lived experiences. Next. As part of our role, we participated in 2 group meetings, one in Nairobi, Kenya, and the other in Cape Town, South Africa, where we came together as a commission to share progress across our work streams, discuss findings, and brainstorm next steps. During our meetings, youth commissioners led sessions on their focus area and facilitated reflection discussions with other commissioners. So for me, my focus area was youth mental health. Next. Another key component of the commission was the involvement of our youth peer reviewers. And during our meeting in Cape Town, these young people, these young advocates were invited to review the draft of the report as part of the writing process. And they ensured that the report reflected young people's priorities and perspectives. This group of 6, we have Nikita in the room, they reviewed for clarity, accessibility, and relevance to adolescents. They pushed for plain language, stronger attention to equity, and better framing of issues like disability justice for youth mental health. All youth reviewers were also compensated for their time, and together we helped to ensure that the commission spoke with young people and not just about them. Next. So one key deliverable by the youth commissioners was the development of the Meaningful Youth Engagement Checklist. And this is a practical tool that was designed to guide and assess youth engagement in research, policy, and advocacy. So you can scan the QR code if you want to see the full checklist as well as the corresponding paper. There were 3 main elements to the checklist. First was authorship and acknowledgement to make sure that young people are recognized for their contributions, whether that means being listed as an author or acknowledged appropriately. Next is aims and methods, which encourages teams to clearly state why youth are engaged as part of the work, describe who exactly was involved, and explain how and to what extent young people participated. And finally is discussion and reflection, which focuses on what difference does the youth engagement actually make in the process. So how did youth input shape the study findings, and what lessons were learned along the way? Importantly, the checklist calls for transparency, shared power, and intergenerational collaboration to make sure that young people's voices truly shape the decisions that affect them. Next slide. Youth councils emerged as a meaningful mechanism for fostering youth engagement, helping to shape priorities, guide programs, and drive advocacy. As part of the commission, we conducted a global study of over 200 current and former youth advisory councils to understand what meaningful engagement truly looks like. And 3 key actions for meaningful youth engagement emerged. 1, click, the integration of the voices and expertise of youth advisory council members into the parent organization. 2, structured and streamlined communication between YAC members and the parent organization. And finally, opportunities and resources for skill development among youth advisors on these councils. Next. Another major contribution to our report, as Sabine mentioned, was the Youth Solutions Lab. And this global effort was co-hosted by the Commission, UNICEF, and the GovLab. We brought together over 200 young people between the ages of 16 and 20 across the world to co-create strategies for improving adolescent well-being. Youth commissioners first helped to identify key areas of focus through a mind mapping activity and voted to determine 5 priority areas, which you can see here. Click. Mental and emotional health care was, can you go back? I'll continue. So mental and emotional health care was a priority, right there, as you can see in the box that's highlighted. The labs were held virtually, enabling young people from various regions to connect despite geographic differences. And each session was co-led by a youth commissioner who helped to facilitate the discussions alongside senior commissioners and partners. Participants selected one priority topic that resonated with them and worked collaboratively to identify barriers, design innovative strategies, and shape actionable recommendations grounded in their lived experience. Participants emphasized the need to address stigma, strengthen access to care, and shift harmful social norms surrounding mental well-being. Next. So as previously mentioned, earlier this year, we did launch our report in Geneva in May, and pictured here is our youth panel discussion that happened at the launch. And so as you can see, young people were center stage at the launch. But the launch was just the beginning, and now comes the real work, translating the report's call to action into tangible change. So this report is a roadmap that policymakers, researchers, youth advocates, and many more can use to strengthen adolescent health and well-being at every level, whether that's national, regional, local, as we're doing here. And whether it's shaping policy, guiding investment, or reimagining what youth engagement looks like, this report has the power to drive real, tangible change. And so as we look ahead, the commission makes one thing clear. Young people must be at the center of this work. We must continue integrating their voices in decision-making, advocacy, research, so that the change is not only for young people, but led with them. So now I'll turn over to Dr. Collins, and she'll share more about youth mental health globally and locally. Thank you.
Thanks so much, Tina. Slide, please. Next slide. So, as you've heard, this is a commission that's about adolescent health and well-being. For these 2 days, however, we've chosen to take a deep dive into adolescent mental health. And so this is, as you can see, has been highlighted by young people throughout the commission. And I want to start by talking about mental health. So adolescence, as you know, is a period of great creativity. Like most adolescents and young adults, the people in this image, these are the commissioners for this study, we're no doubt imagining possibilities for the future, studying, singing, writing, dancing, worrying about their hair, seeking comfort in friends, and organizing to the best of our abilities the lives that we live. And why is that? A lot's happening in the brain during adolescence. Like, after infancy, adolescence is the most dynamic period of brain development. It's not only a period where neurons are highly adaptive or lots of plasticity, as we say, but a focused period of pruning and differential maturation. And this begins around the age of 10 and ends sometime in the mid-20s. The brain's reward system is remodeled, the prefrontal cortex develops and strengthens the ability to plan, to make decisions, to weigh outcomes by late adolescence. And this plasticity of the adolescent brain also provides the potential for strengthening responses to childhood trauma and distress. It's a critical period of development, during which there's heightened sensitivity to external and environmental stimuli. And most mental disorders that are present in adulthood emerge during adolescence. Substance use disorders also tend to emerge during this time, underscoring the interactions between neurodevelopment, social development, and environment around us. So I want to spend a few minutes taking a deeper dive into the prevalence of these conditions in adolescence. Next slide. So how prevalent are mental health conditions among adolescents globally? Globally, around 1 in 7 adolescents lives with a mental disorder. These are data from the 2023 Global Burden of Disease study, just published that show a sample of countries across various regions in which an estimated 14 to 32% of adolescents are living with a mental health condition. You can see from this that prevalence may vary across different countries, and we would expect to see some variation within these populations based on people's experience of adversity, as well as the protective factors in their lives. In adolescence, those tend to be healthy family relationships and communities, as well as positive school environments. The prevalence of substance use disorders in this sample of countries is also quite variable, with a low of less than 1% in Nigeria to a high of nearly 8% in the United States. The next slide shows data from the United States specifically, where the prevalence of any kind of mental disorder hovers between 22 and 24%. For adolescents across, as you can see, we've got Maryland, New York, Mississippi, Tennessee, the District of Columbia, Alaska, California, Washington, and Georgia in this image. And around 6 to 10% of adolescents meet criteria for a substance use disorder. Next slide, please. Of course, one of the major concerns during this period of life is suicide. It's a leading cause of death globally among 15 to 29-year-olds. Second leading cause of death for females around the world, and the third leading cause for males. And as we'll hear more about with our next discussion, our region of the world, the Americas, is the only one in which suicide rates increased from 2000 to 2021. Next slide. Despite these data, they're really showing us what the needs are. Investments in mental health are low. Globally, the median reported expenditure on mental health is about 2.1% of government health budgets, with tremendous differences between high-income countries, which in this sample spend around 4.5%, and lower-income countries, which may spend less than 1.5% on average of health funding. The median reported expenditure per capita globally is $2.69, again, with vast differences between low-income countries and higher-income countries. Next slide. As a commission, we emphasize the need for investment in adolescent health. And our analysis of development aid for adolescent health shows that investments in adolescent mental health remain vastly mismatched with the scale of mental health needs. And if you're wondering what these colors briefly, the red, and I need to just look here at this legend, you can see that the countries in red are showing a less than 5%, less than 5 cents investment in mental health. So self-harm, depression, anxiety account for sizable healthy years of life lost in adolescence, but only about 0.2% of total development assistance for adolescent health is dedicated to these issues. Next slide. And not surprisingly, these limited resources for adolescent mental health are reflected in limited numbers of providers. Around the world, there are 3 child and adolescent mental health providers per 200,000 population, and comparatively many more mental health providers addressing adult needs. So what are some of the drivers, next slide, of adolescent health and mental health? They're both new as well as neglected drivers. One of the new ones that we bring attention to in the commission is the triple planetary crisis of climate change, biodiversity loss, and pollution of air, water, and soil, all of which do have mental health sequelae. These increase the frequency and severity of climate-related disasters, and displacement resulting from these kinds of disasters can lead to insecure housing, isolation from community, which of course carries both effects on well-being and mental health. And often it's the most vulnerable who experience these assaults. Commercial determinants, as Sabine mentioned, are also often deliberately targeting adolescents with messages from food and beverage companies. And in the United States, commercial interests are also linked to overdose deaths, where opioids are the 3rd leading cause of death for people under 20. Conflict and displacement pose growing threats, and between 1990 and 2022, the number of adolescents living close to deadly events more than doubled. Again, living near conflict erodes the protection of families, schools, and communities. And we'll talk later about how to address these kinds of mega trends that are influencing adolescent mental health and well-being. Next slide. Next, you can click through. Okay, stop. So the good news is that there are many effective approaches supporting youth mental health. There is increasing evidence of effectiveness of school-based interventions for mental health that are inclusive of promotion, prevention, as well as responsive care. And these require strong collaboration between health, education, and social welfare, as well as child protection, as well as the collaboration of families and communities and in which young people live. Next slide. We also know that adolescents are more likely than any other age group to live in cities. And cities can help support resilience, mental health, well-being, and positive development in young people by implementing policies and programs across different sectors. These efforts can be particularly effective if they address key aspects of adolescent development, such as identity development, interdependence, self-determination and preparation for careers, connection with peers, and exploration of new opportunities. Schools, as mentioned before, can play an important role, as can career and employment preparation, civic engagement as well, and engaging in creative activities. And we'll talk more about those options later. Next slide. So how do we move forward? Central to effective action is the meaningful engagement of adolescents in policy, research, interventions, and accountability mechanisms that affect them. You've heard a lot about this, the importance of youth engagement. But this is a unique moment. Mental health is front and center on the global stage right now, and it remains a priority domestically. Young people here and around the world are taking their mental health seriously, and they're talking about it, and they have a lot to say. Next slide. So I want to close by reminding us that adolescence is a dynamic period of remarkable opportunity, creativity, learning. Investing in adolescence yields a triple dividend, benefits adolescents now, the health of the adults they will become, and benefits for the next generation. I want to also be clear that adolescent health and mental health are intertwined. There is no adolescent health without mental health, and poor physical health has implications. So I don't want to make an artificial distinction between health and mental health. So some of the things we'll talk about in broad swaths and some in detail over the next couple of days are how do we create the enabling environments to transform adolescent health and well-being, how we can amplify actions within existing systems to address adolescent health and well-being, and how do we develop innovative approaches to address these complex and emerging health threats in partnership with adolescents to support their mental health. So thank you. And with that, I'm going to welcome our next panel. Thanks, everyone. Okay, I'd like to welcome to the stage, let me see where you all are, Dr. Fouzia Shafique, Renato Oliveira, and Alyssa Lord. Please come to the stage. And let me introduce this panel of speakers. We're going to set the stage for our conversations about adolescent mental health and implications and opportunities of the Second Lancet Commission on Adolescent Health and Wellbeing. Fouzia Shafique is UNICEF's Associate Director for Health, leading global efforts in maternal, child, and adolescent health, primary care, as well as community health systems. She is the former lead for UNICEF's global portfolio on health responses in humanitarian emergencies. Renato Oliveira Souza is Chief of Mental Health and Substance Use Unit at the Pan American Health Organization. He formerly served as a consultant for the Department of Mental Health at the WHO headquarters in Geneva. And Alyssa Lord is Deputy Secretary of Behavioral Health at the Maryland Department of Health. She brings more than 20 years experience in community and population health, working collaboratively across local, city, state, and federal entities to improve mental health outcomes across the lifespan. So we've got global, regional, and very local perspectives here on the stage. And you'll see that throughout the course of these 2 days, really looking at global data that helps us think about how do we act here? How do we act locally? So we're gonna let you first tell us a bit about yourselves and tell us a bit about the work that you do. I'll just start with the first prompt and let all of you speak a bit. You have mics here, so make sure that your mics are active. So youth mental health has risen in priority in public health in recent years. Can you tell us about how your organizations envision their role in addressing youth mental health, and tell us about how youth mental health aligns with broader strategic priorities? And let's start with you, Fouzia.
Test. Can you hear me now? Yes, okay. Thank you, Pamela. Good morning, everyone, and good evening and good afternoon to any colleagues who might be connected from around the world. Thank you for joining us today, everyone, and thank you for having me, Pamela. I have to first say that I cannot claim to be an expert either in physical health or in mental health. I'm a public health practitioner and already have learned a few things this morning, and I'm looking forward to learning a lot more over the next day and a half. Now, it is, of course, encouraging to have a Second Lancet Commission that brings renewed vision to adolescent health and well-being. Those of us who were at the UN General Assembly last month were really happy to see that mental health was not just a side topic, but was a central theme to so many of the global discussions, whether we were having discussions on LCDs or discussions on broader adolescent health or emergency preparedness or humanitarian response. Mental health was a central theme in many of these conversations. Now, the reason it's encouraging is that, for all the reasons that we've already heard this morning, but also because solutions to many of the problems that our world is facing lie in probably three things. And these are human capital development, economic resilience, and in sustainable development. And mental health, especially adolescent mental health, is central to solving all of these issues. Now, you've shared some really important figures with us, Pamela, but if I could just maybe add to that a little bit. There are around 1 billion people who live with mental health issues around the world. That is a frightening and staggering figure on its own. But if you look at it in a little bit more detail, you realize that half of these 1 billion people started showing signs of mental distress and developed those mental disorders when they were still children, when they were less than 18 years of age. And that is a reflection of the kind of world that we've built for our young people and our children. In addition, we have around between 35 and 40 million young people who will face climate disruptions. We have about the same number that faces displacement because of conflict and other vulnerabilities. And 1 in 7 adolescents are living with diagnosable mental disorder. Now, I say diagnosable mental disorder because many of these adolescents have not been diagnosed. And even those that have been diagnosed will probably not get the kind of care that they deserve. It's also important to look at this not only as an individual issue, because it isn't. Both the determinants of the mental health issues in adolescents, but also the way they present depends on where that adolescent is. And so these actually, we mentioned some of the figures around conflict. Of the 4.8 million children that we lose within the first 5 years of their life die in settings of conflict and fragility. And this is just a reflection of the kind of distress that these children, their peers, their siblings, their caregivers are facing. We know that as these children grow older, around 250 million children will be out of school, because all the factors that we know keep children out of school. We know that 1 in 7 adolescents reports heavy drinking. In Maryland alone, 40% of the school-going children report feeling sad or depressed at certain point. So if you're going to talk about solutions to adolescent mental health,
they cannot only be embedded in the health sector. They have to be determined based on the determinants of the reasons of mental health issues in adolescents. So it has to be solutions that come not just from health sector, but from education and social protection and digital space as well. Now you asked about what we as UNICEF are looking into doing. There are three things that we are looking at. One is investing, second is integrating, and third is including. What I mean by investing is, if you look at the cost of inaction in adolescent mental health space, the numbers that I provided talk about the number of people and their families that are impacted. But we're also talking about around $387 billion in lost human costs because of inaction in this space. The Lancet Commission is warning us that there might be a loss of 7.7% of the global GDP if we don't act now and act decisively. And that's why at UNICEF we're talking about investing. We're asking the high-income countries to invest as much as 10% of their health budget into mental health, and low and middle-income countries to invest around 5% of their health budgets into health. But it's not just about putting the money into mental health. It's also about which interventions we look at. Most of the time, the 2% that you mentioned ends up being in institutional and specialized care. And that is needed. But what is needed even more is to invest in services that are available to adolescents near their homes and their communities, in their schools, and at the primary healthcare level, not only at the specialized level. The second thing we're talking about is integrating. And so mental health cannot be treated as a silo because its determinants and its representation is not siloed. And so we're talking about, as I just said, bringing together health, social protection, education, digital space, and many others into play as well. It has to be a consolidated approach that takes into account what the adolescents are living through. And of course, it has to be different depending on where you are. How you treat a child who's facing mental distress in Maryland would be different from how you treat them in my home in Rawalpindi in Pakistan to how you would treat a child who's facing what children are facing in places like Gaza and in DRC and in Sudan. And the third thing, which has been spoken about very eloquently by Tina this morning already, is include the adolescents. Not the way we used to do in the past, just nominally, but in a way that they are part of the decisions that are being made, strategies that are being developed, because we've seen now in many countries that when adolescents and their families are meaningfully involved, the services are of higher quality, their uptake is better, and their impact is profound.
Thank you very much. So we'll just move along and over to you.
Well, thank you, Pamela. Thank you, Pamela, and it's a pleasure to be here with you. And I think it's very important that we that work in mental health, we try to have very clear and objective messages to policymakers. For us, working in the region of the Americas, the messages are we need to increase investment in mental health. We need to increase financial resources, and we need to increase human resources. Otherwise, we are not going to be able to provide the support that we have been discussing here. Now, beyond that, there is another very important message, which is the intersectoral work. And when we are talking about adolescents, especially schools and the health systems, both have a huge work to do to advance the mental health of adolescents in the region of the Americas and certainly globally. And it's very sad to say that the mental health of adolescents in our region, the region of the Americas, a region with 35 countries, is in very bad shape. And what is even worse is that it's not improving. And I'm going to bring you some data that shows why the situation is like this. If we look into anxiety and depression, now with data from 2021, it's number one and number two causes of years lived with disability in people from 10 to 24 years old. Let's look back at the year 2000. It was the second and fourth. Let's look at your substance use disorders in the Americas. It's the sixth leading cause of death in 10 to 24 years old in this region. And there has been a very sharp increase when we compare with the year 2000. because it was the 18th leading cause of death in that group at that time. Suicide, it has already been mentioned, but it's very important to emphasize, it's the third leading cause of death among adolescents in the region of the Americas. And again, a sharp increase when we look at data from 2020. We know that all this is permeated by social determinants. And here in the region of the Americas, we have poverty, we have inequities, violence. In the region of the Americas, we have the highest homicide rate in the world. The phenomena of migration contributes. We have in this region almost 8 million migrants under 18 years old. There is an estimation of around 1 million adolescent girls being victims of sexual violence in Latin America and the Caribbean. And of course, the challenges of digital spaces also contributing to the situation that I'm describing here. Let's start with the bad news and see what is the response. What are countries doing in order to overcome such a problem? Well, it's also not something that I would be happy to mention here. Less than 50% of countries have a national policy for adolescent mental health. And I'm not mentioning only standalone policies, but also integrated into general health policies. 50% of the countries in this region only have outpatient mental health facilities that can support people in the community. So, as you can see, if we don't change the situation from a political perspective by increasing the relevance, increasing visibility, and showing how it's important to invest in mental health, I don't think we're going to be able to change that data. So the Pan American Health Organization, putting adolescent mental health at the top of the public health agenda in this region is a priority. We have done work on creating regional policies. Recently, we have worked with the Organization of American States, and there is even a new resolution on general mental health, which is with a strong component of adolescent mental health, that there are member states from the Organization of American States have put forward in the form of a resolution, which is a good direction, showing that it's not only the health sector that is concerned, but other sectors, other ministries also understand the importance of investing in mental health, including adolescent mental health. So there are many things that we have to do. The problem is not simple, but again, increasing investments, financial resources and human resources, and working from an intersectoral perspective, where every sector has a role to play, is the pathway to improve the situation. I'm very much looking forward to your perspectives and your experiences on how we can do this in a better way. Thank you.
Thank you very much. We'll move on to Alyssa.
Good morning. Can y'all hear me? Okay. So thank you for the opportunity to speak with this incredibly distinguished panel here this morning, and grateful to speak on behalf of Maryland. So mental health, you've heard Dr. Collins say this, but mental health is health. And at no point in time are we able to separate the head from the rest of the body. This is also especially very personal for me in that I have an 11-year-old daughter who was diagnosed with ADHD and anxiety, but she also has asthma. And never once has she asked me, Mama, why do I have asthma? But asked me, why do I have anxiety and ADHD? And so in the state of Maryland, suicide is the third leading cause of death for young adults and transition to age youth. You heard a little bit about the percentage of Maryland youth who struggle with feeling sad or hopeless. We see these numbers even higher for those that are LGBTQIA, and we often think that these numbers are highly underrepresented in our diverse communities and communities of color. We have seen We've all probably seen the reports that have come out around the increase in depression and anxiety as a result of social media. We have seen in the state of Maryland an increase in the number of youth with co-occurring mental health and substance use diagnosis and co-occurring behavioral health, intellectual disability diagnoses. And so while we don't want to paint an overly bleak picture, what does this lead to in the state of Maryland? So we have seen increases in the number of youth that are being diagnosed with highly acute complex needs that are requiring the highest and most restrictive levels of care. And when I joined the department 2 years ago, little more than 2 years ago, maybe it feels like dog years now at this point, we started to take a look at the data. And what we saw is for the programs that we had established for Maryland youth, first and foremost, we were not seeing the uptake for our most intensive home and community-based services. And when we asked our families and youth, why aren't you using them? And they said, well, it requires 17 assessments in which we have to score a certain way, 32 authorizations, and then maybe if we're lucky, we can find one provider who accepts the referral. We said, okay, that's not going to work. And then we also took a look at our early and periodic screening, diagnosis, and treatment data. And what we saw was we did pretty good in the early years, but as our kiddos got older and were entering adolescence, our EPSDT screenings just landslid. And we said, okay, well now this also now makes sense as to why we are seeing the increases that we are seeing in our emergency departments, in our inpatient stays for our adolescent use, particularly for young adult males and females, because they may be going in for their sports physicals, but the providers and their pediatricians are not doing those EPSDT screenings. And so what we did is we have reinvested in behavioral health in the state of Maryland for our youth. We actually worked for more than a year to issue what we have now called the roadmap. And that lays out 5 goals that are meant to be aspirational yet attainable. And we are looking to go upstream and be much more proactive than reactive. So, for example, we have decreased the threshold for our families to access our 1915I services. So there's no more a multitude of different screenings and assessments. You score what you score, and then it determines what level of care that you need. And that meant we have to expand those different levels to targeted case management 1, 2, and 3. So what we tried to figure out is how we translate our data into something that is actionable and meaningful for our communities. And so we see this as part of the broader behavioral health continuum of care. And we see this as how we integrate across our different systems of care so that our care delivery system doesn't matter whether you're diagnosed with ADHD or anxiety or depression. It's that you have the ability to access these services through whatever door you enter, whether it be through outpatient mental health services, whether it be through seeing your pediatrician, or whether it is through our school-based mental health investments that we've been making. So we still have a long way to go, don't get me wrong. But I think, for us, we see this as part of how we care for our children and our families. That's the other piece that I'll end on is when I first joined the department, all of our programs were constructed just around children. And I said, when our kiddos are in crisis, our families are in crisis. So if we're not providing the necessary supports for families, however broadly defined that we need to define them, whether they're living with an aunt or they're part of the foster care system or engaged in juvenile services, then we are missing the mark of how we think about providing integrated care. So we have spent a lot of time trying to build up the same continuum for our children to make sure that they are inclusive of family or other systems so that the interdisciplinary care team is talking with one another. So this also speaks to this notion around collaboration and communication.
Great. Thank you very much. So let's thank the panelists and then we'll move over to the That's great. Now, I appreciate all of the points that each of you made, and you've highlighted the problems very well, very clearly. And I want to just start with maybe start with something that we talked a lot about crisis, what are the problems that people are having. And you all alluded to the need for community services. A complaint that I've heard from young people in other parts of the United States is, I can't get any attention before I'm in a crisis. I can't, and how do we do that? So I just want you to talk a bit more about access there, but what does that look like in communities? And then I'm going to ask you to move beyond that to good examples of ways that communities can support mental health, the examples that you might have.
I'm happy to start.
Yeah.
So one of the things that we've done is expand access to our crisis through 988 and our mobile crisis services, because we also want to recognize that we have to meet where they're at and where they feel comfortable in receiving services. So 988, we've actually been tracking this data over the past year and a half or so, but we have seen dramatic increases in the number of adolescents that are calling 988, and they're calling during the school day. We often have partnerships at the local levels around 988, and what we're also seeing is an uptick or a relationship between the local school districts and the mobile crisis units. So what's happening is that maybe in the past where they would have called the police to intervene, they are calling for mobile crisis to come on site or ensure a warm handoff in another location, trying to protect the anonymity of the youth. So we see the investments in mobile crisis and crisis stabilization services as something that's absolutely critical. This is also partnered with what is called MRSS, which is basically the follow-up after a crisis, where we follow a youth and their family for 2 weeks, although we're pushing really hard. None of our providers actually only stick with a family for 2 weeks, but we're pushing really hard to extend it for up to 8 weeks so that we can make sure that we are ensuring those linkages to care and services in the community. Now, that being said, Maryland, like many other states, have been hamstrung by the behavioral health workforce shortage. And so what we sometimes find is we are having Marylanders who have to cross into other jurisdictions, which is subpar, right? If we're trying to keep families, and depending on where they are in the state of Maryland, I don't know if any of you have ever visited the Eastern Shore, which is absolutely beautiful, or Western Maryland, which has some underrated good skiing. But that being said, getting from point to point is very, very difficult. I'm sure not dissimilar to other parts of the world where transportation, the straps to the social determinants, make it really hard to create access. So we are looking for, through the rural health transformation money that was just released by the federal administration, to continue to grow and reinvest. And we are looking at telehealth and mobile units to help further support that. We have telehealth infrastructure now, but we feel like this is a great opportunity to make sure that we're identifying new resources. The other thing that we've done is we have organizations or providers that have expanded their footprint beyond tele and have developed other web applications or follow-up mechanisms, such as surveys or engagement strategies via cell phone. Now, that's a little bit of a slippery slope, particularly when we think about social media, but these are technologies that we have vetted very, very closely to make sure that it has the appropriate clinical prompts, and when it detects that maybe that this youth is in need of a higher threshold of care, that they're being linked expeditiously to the right setting and level.
Thank you. I want to go to, that's great. That's actually quite striking that kids are calling from school but using it. So that's wonderful. And also, can we talk about the workforce in the Americas? What is the mental health workforce? What are some solutions? We know that everywhere in the world we don't have enough youth mental health providers, as we saw from the data that we showed data, but what's happening in the Americas around training for increasing the workforce?
Well, perhaps I can start by saying that I have described that crisis situation, but the Americas is also a region where you find a lot of solutions for those problems. So most of the time when you look around, you will see a country that has tried something that can present results and that can share that experience. Some of the examples that we have here that we rely upon when we are also supporting other countries, we have the example of Chile, At a certain time, Chile saw mortality by suicide increasing, specifically in the population of adolescents. So they launched a program where teachers, directors of schools would be trained on how to promote mental health, how to strengthen resilience, but also how to identify adolescents in distress and then connect to the health system. Chile has also a strong integration of mental health into primary health care. So by making those connections, by developing that model, and then expanding gradually towards other regions of the countries, they could observe a reduction in suicide mortality among this specific age group. That for sure probably was also influenced by other factors, but I think it's interesting to see a very targeted approach with the identification of a problem and launching an intervention that has different components. And I think in parallel to that, all the work that we have been doing, other organizations have been doing, that we do in partnership with UNICEF on integrating mental health into primary health care, connecting to the school environment, developing the capacity of schools on the delivery of social emotional skills, bringing the community together, creating groups that can support adolescents in difficult situations. I think it's not so documented as in other areas, but I think if we are able to help countries to document those experiences, it can be of use to many other countries in the region and also beyond.
I want to just, I know that UNICEF and WHO, and certainly the regional FAO as well, have worked together around supporting mental health and supporting the training of people who are delivering those services. Do you want to say anything about any of the work in the workforce? But I did want to talk maybe briefly about the really resource-constrained settings, because I think we do have better resources available in Meriden, but also in many countries in Latin America as well. While it has become easier to talk about mental health compared to 10 years ago, that is certainly not the case across the board. So there is still a lot of work that needs to continue to be done to make it easy for people to talk about their own mental health concerns and those around them. And there are many, many countries where it's still the taboo that it was in communities in Americas, for example. So that certainly needs to be done. Secondly, I think adolescents, they must have options, because all of them react differently, right? It's unique for everyone. So in Africa, for example, there's a little over a million community health workers. I spent 4 years in Afghanistan at 2 different times. There's 30,000 community health workers in Afghanistan. So how do we use whatever is available in a certain country, in a certain community, for adolescents to reach? Teachers and nurses in schools, social workers, community health workers who have the trust of the communities, but also how to link them. Because we see a lot of cases of adolescents reaching out, and then when they need to reach out again, they reach out to a different channel. And if those channels are not connected, we might be missing opportunities or missing trends. And therefore, it's important that all of those who are in the adolescent ecosystem are connected, and therefore digital connectivity and the digital solutions need to come together as well. But we also have a lot of evidence that when you go beyond the adolescent herself or himself and include their families and include their peer groups, then you get exponentially better results in that early part of the intervention, in promoting better behaviors, in promoting, staying out of the risks, in early prevention, in early detection, and in early care as well. I remember walking into a clinic in Afghanistan, of all places, where a family counseling session was going on, and I was invited to sit through it. It was an adolescent who had attempted suicide, and as part of the treatment, they were doing a family session. And 10 years ago, this would have been unthinkable in a place like Afghanistan, let alone in a remote area in eastern Afghanistan. But having the parents, the siblings, and the child who was impacted sitting in one room and discussing it, it's tremendous progress. That's wonderful. So thank you. You've all given incredibly rich examples. I want to go from there to talk about something you've all alluded to, which is, how are you working to hear from adolescents? How do you engage adolescents and their communities? If Maryland is developing strategies, good examples from the region, UNICEF. How are you doing this? How are you engaging young people, engaging communities in the work of thinking about mental health?
I think there is a lot of work that we still need to do in this area. So at the level of the headquarters of PAHO, we have a youth group that is asked to be involved and participates in all the activities that we develop for adolescent mental health. Recently, some of you might have joined us. We commemorated the Inter-American Mental Health Day for the first time, and the theme was on child adolescent mental health, and the youth group was invited to come discuss with us how they wanted to organize the activities, the webinar, and they had a specific section discussing the priorities for them. But when we go to the country level, I think that's where the challenge lies. In many countries, we will need to change the status quo. We need to be brave enough to bring youth to the forefront of the development of services. I think we have been doing in some countries, especially when we work with ministries of health in the development of a national mental health policies, where there is a proactive work on inviting all stakeholders to participate. But no doubt, I think that's an area that we are very behind. We need to be creative. We need to create models of doing that in a way that then good models can also be replicated.
You said something very important this morning about not just listening for ideas and feelings and experiences, but also making them a part of solutions, right? So just to take an example, in many countries where we're asking the adolescents on helping decide how services should be delivered to them, who should deliver them, what should be the timing, what should be the modality. So they're not just telling us about their experiences and what they want, but how services should be delivered for them. And we are seeing again and again that when services are developed, interventions are developed and delivered in ways that adolescents have identified themselves, then we get the best results.
I think there's a lot of evidence out there about integrating those with lived experience into your service model. So one of the things that we have been doing is in the state of Maryland, there's the formation of the youth mental health pool. And so while that is looking at transition age youth and young adults, integrating them into the care system delivery model, that is our first foray. And then as we look to continue to expand our 1959 services, there is a youth peer support component. Again, we have a lot of experience. We've done this through the substance use space for decades. And so we are now making that pivotal leap into making sure that we are doing the same on the mental health side. And then also trying to figure out how to cross train on both mental health and SUD. And then we will be folding in around intellectual and developmental disabilities as well, because we think that's an important part of the schema. I think the other piece where we see the youth voice is Maryland is notorious for commissions and work groups. We have great relationships with our legislators, but basically any piece of legislation enacted in the state of Maryland oftentimes has a work group or a commission that's attached. But what we have done in partnership with our General Assembly is making sure that for every work group and commission, it has a seat, multiple seats at the table for individuals with a behavioral health diagnosis or family members. And so I have the great privilege of co-chairing one of our youth groups that is solely focused on addressing the needs of youth in the state of Maryland. And our youth and family member participants are just absolute lightning rods for telling us what we're doing well and what we're not doing well. And not only that, being incredibly solutions focused. So much of the work that we did around 1959 was as a result of all the feedback that we received, thinking about youth mental health groups or peer groups. That has all been generated by their really forward thinking and pushing us to say, we have a seat at this table, make room for us because we do this day in and day out. And also they remind us that adolescence is hard, right? I think we talked about it here a little bit about, your brain and body is working in a multitude of different directions, but we also need to stop and take a step back and go, okay, what makes it so hard? And how are we as adults who are trying to construct this set of services, making it even harder for kids and our families to be able to access that? And so we then take that feedback and we bring it back to our provider community, right? And I can say, when I relocated, I tried to connect my daughter to services, and I called a very large academic institution. They said, call back next week. We don't have any appointments. Okay, called back the next week. We don't have any appointment. Call back next week. I called back the third week and they said, oh, what insurance do you have? I told them what insurance I had. They said, oh, that's good insurance. Thank you, state of Maryland. But they said, oh, we still don't have any appointments available. And I thought, I didn't identify my role. I didn't use, prestige of position. I didn't say anything. And I just thought to myself, by golly, if this is what I'm going through for somebody who doesn't know how to navigate the system, what does that mean? And so started outreaching to our family members who are participants in the public behavioral health system in Maryland and said, tell us about your experience. How hard was it to get an appointment? What does consistency of care look like for you? How many different providers have you had to navigate? And so it's almost like the equivalent of a net promoter score, or utilizing a different sort of survey techniques that both formal and informal to elicit responses so that we can continue to innovate on our model, which is certainly not perfect, but without that feedback, the only way we're going to continue to make it better.
But let's just take a quick minute. What we are saying about, all three of us are saying about involving adolescents doesn't apply to mental health issues for adolescents. It applies to everything that adolescents are involved in, whether it's non-communicable diseases or injuries or how to bring our school kids back to school. I also wanted to remind us of the Kigali declaration last year, where some 40,000 youth through their youth leaders came together, and there was a declaration. If I don't get the words wrong, it was nothing for us without us. And so everything that's being designed has to be designed by them. And not only is it a good principle in terms of inclusion, it also gives much better results with respect to the data.
Absolutely. And thank you for sharing those examples, all three of you, and for acknowledging where there's a need for growth in this area. So we've been talking at you a lot, and I want to give a chance for the audience to ask questions, for those of you who are online to ask questions of our speakers. If anyone has questions in the room, start to just go to the microphones on either end of the step. And while actually I was going to ask you another, but I'm going to wait till the speaker get to the mic and start off.
Good morning. Thanks, Pamela. It was quite rewarding to hear the last intervention from the secretary, the Maryland secretary. She mentioned something that we tend to forget as the root cause of some mental health disorders among the youth. And that's the issue of substance use, abuse, the issue of violence, the readily availability of arms. So, and this is certainly the case in the Americas. So for Renato, the question is, how we go about connecting the mental health service delivery approach that has more or less a reactive nature with preventive interventions that will address drug addiction, drug trade, violence, and also the whole issue of lack of opportunities for youth, particularly to get a meaningful job that will allow them to make a living. Thanks.
A very simple question for you.
Yeah, I wish I had the solution for all these, Patricio, but I think there are windows of opportunity that we could use to make things better than what we are already doing. Fortunately, the area of mental health has had important advances in the last year. So I think in using those advances in mental health as a platform to deliver interventions for prevention of substance use disorders, but also early identification and support using the networks that we have in the health system could be an opportunity to tackle some of those problems. And one other thing that I wanted to mention, which I think is connected to your question and also connects us to a discussion more on global mental health, which should also apply to adolescent mental health, is how can we do better by bringing the skills that traditionally were among mental health professionals to people who are working in the community, in the health systems, but are not specialists. I think we learned a lot in the area of, for example, HIV/AIDS. We are learning in the area of mental health, but I think all these learning could also apply to the area of diagnosis and management of substance use disorders. So how can the community health workers promote mental health and deliver interventions at the community that can reduce some of the burden, some of the mortality that we have discussed here? How can the primary healthcare system be equipped to implement early interventions for the management of substance use disorders that could also help us to tackle some of those problems? No doubt, more complex conditions will need referral to specialists, but we will be able to do a lot, I believe, if we work at the primary healthcare level, at the community level, using the capacities of non-specialists. And no doubt, the school environment is another place that many of those interventions can be implemented. I'm sure colleagues from UNICEF will be in a better position than me. And perhaps the last point, Patricio, you had also mentioned the area of promotion and prevention. Again, I'm a firm believer that the health system has a major role to play. And the health system, well connected to the school environment, could tackle many of those challenges that we have been discussing here. But nothing will advance if this that we are discussing here does not become a political priority in the countries. Nothing will advance if the different sectors understand the role that they can play to tackle some of those challenges. And I think this is where we should put a lot of emphasis. In meetings like this, increasing the visibility, bringing the data, showing the expertise of some areas, exchanging those experiences. Because unfortunately, in low and middle income countries, the situation is very dire, and the results need to be using creative approaches.
Thank you very much. Let's take our question from this end of the room, and we'll come back to them.
Okay. Hello, good morning. Good morning, everyone. Thank you for having us. Thank you for having this thing here, this informational session. I have two questions for you guys if you have the time. My first question is, are there any policies or practices put in place to build community?
We have policies and practices in place that can help to build community. We have examples.
So in the state of Maryland, this has been a core priority for the Moore Miller administration. So there's something called the Enough Act, which was taking a look at particular communities across the state in which they were under-resourced, but we saw it was basically broken out into three different phases. So those that were sort of early on in building community capacity, those that had their foot in the sand, but like were in the process of trying to figure out what does this plan around reinvigorating and developing community look like. And then the third tranche, which was those communities that had figured out where did we want to invest and what did that look like. And that was across multiple stakeholders. So it was faith-based communities, it was intergovernmental, it was education, it was criminal justice. And so that process is run through our colleagues at the Governor's Office on Children, actually, who we work with really, really closely, but they're leading those efforts. And so they're working with 5 distinct communities across the state of Maryland to help flesh out, depending upon where they are. And they really are defining what is sort of the core set of criteria for what they want their community to look like and what they want to execute on, all with the goal. There are a couple of core goals, but one is around addressing intergenerational poverty. One is around access to healthcare services. And then there's another corollary around young adults and particularly young men of color. And trying to figure out how do we make sure that we're building capacity and capabilities for access to career pipelines and college and all of those things. And so each of those communities, their plans are relatively public, but that's just one of the approaches that we've taken to a policy lever of saying, let's identify a couple of core communities that have already decided in some way, shape, or form how they all want to work together. And I'm really excited to see what happens over the next year because they've each taken a different approach to how they want to do it, but they're all talking to one another. So I think it goes back to sort of that peer group and establishing that notion of connectivity and collaboration.
Thank you. I definitely feel like with mental health, it's like I work with a mental health company, and when I'm out in the community a lot, and in the Baltimore area, especially when I'm interacting with people that might not be as receptive to mental health, I kind of change my language and verbiage of it, and I kind of position it as well-being more than anything, because it's really just taking care of yourself. And I forgot who exactly on the panel mentioned it earlier about how your head can be attached to your body. And too often mental health, I feel like, has been positioned in society as well as health practices as like separate from like health altogether, but they're one and the same. And I believe it was you that had mentioned how there are now more like pediatric practitioners incorporating mental health assessment in that room. I feel like it goes hand in hand. If your mind isn't right, your body isn't gonna be right, and vice versa. So thank you for that. And my second question was, are there any more groups or organizations to address problems that is not the police? Someone had mentioned earlier a crisis unit or mobile crisis unit. So I'm interested in figuring out what other organizations out there that adolescents, but anyone can reach out to in crisis that won't necessarily direct them towards the police. Because sometimes I feel like with adolescents, in particular, if the community I serve, they are hesitant to seek out help because they have the fear that the help that they will receive will be closely associated to law enforcement, and they feel like that can escalate whatever crisis they're currently going through. Many different factors and reasons.
Thank you. So that's a question about alternatives to the police when there's a problem.
So 988, which is a toll-free number, right? You can be completely anonymous. And for about 95% of the calls on 988, the disposition is resolved on the call, or you are provided with linkages to referrals, but then 988 does follow up. And they do say, were you able to connect? Same with mobile crisis, depending upon the type of crisis. The goal, at least for the Behavioral Health Administration, is to deploy a clinician along with a peer in most instances. And so depending upon the type of call that comes in, unless we know somebody may present with a weapon, our goal is to make sure that we're sending a clinician into the field every time to mitigate before a police response. And so those have been our two main vehicles for how we still work closely with the police department. Oh, the other thing I will say is we are actively working on warm handoffs between 911 and 988. So calls may come in through 911, but we have a partnership with 911 to try and figure out what is the escalation pathway or de-escalation pathway from our perspective about making sure that the call is being routed to the appropriate.
Okay,
Thank you for your questions. Thanks. We'll just take one last question and then we'll break.
Sure. First, I just want to say it's really exciting to hear Deputy Secretary Lloyd talk about the Governor's Office for Children. I'm actually here on behalf of the Maryland Youth Advisory Council, which is under the Governor's Office for Children. And so that was really thrilling to hear. And so as Deputy Secretary Lloyd outlined, including youth stakeholders in decision-making processes and policy development is crucial to making effective interventions. And so for anybody on the panel, how do you kind of circumvent institutional or financial or social obstacles in areas that might not be as accepting of youth involvement and youth engagement to make sure that policies are still effective and interventions are still through? Thank you.
So, you ask a really important question, because if you look at the number of countries that have really good, strong policies and strategies in place, there's quite a few. But then there are just as many that are not being implemented. And what we are learning through our work with countries is that you have to go into the details of how those policies will be implemented. And I'll give an example. In one of the countries that I worked in, mental health interventions was part of not only the expanded package of services, but also the minimum services package. But it's not broken down into what do you mean by mental health intervention? And therefore, when we started looking at what exactly was being done, almost nothing was being done. So you have to break it down by what do you mean? Who is responsible for making sure that they are looking out for signs of mental distress? Who do they refer to? What does that person who receives the referral do? And if there is further referral needed, where does that go? When and how do you involve caregivers and others? So it has to be spelled out in the services package for it to actually be done. The second thing is trained health workers. You're talking about in Maryland not having enough health workers, and this is a relatively well-resourced setting. So we can just imagine what's happening elsewhere, and that is why it's important to use the resources we already have available. So the community health workers, the school nurses, the teachers, the social workers, to have that at least enough training to be able to identify and refer so that we are preventing rather than dealing with crises. And then the third thing is for having measurement systems in place. One of the things that we did not get to talk about, but which was mentioned in our very first presentation of the day, was how we have been talking about the numbers, adolescents who have this or that mental health issue. But what we don't have very good data on is what kind of services are available and are being used by them. So our health management information system at the health facility, at the community health worker level, and the education management information system, information coming out of the nurses or the social workers office, needs to also be able to tell us what services the adolescents are accessing, what is the quality of those services, and what are the results that those services are giving us. And this commission is going to now enable us to work with countries to put those systems in place as well.
Thank you very much. We're out of time, and I want to thank this panel, Dr. Fouzia Shafique, Dr. Renato Oliveira-Souza, and Deputy Secretary Alyssa Lord, who've given us really wonderful, broad, global overviews down to the local. And I think one of the takeaways that I'm hearing is that you've all got wonderful examples of actions that are being taken and can be taken, but political will is an important piece of this. And one of the roles of people in this room, and we'll keep talking about this, is how do we actually use the data that we have? How do we use these examples to advocate, right? To figure out where are the solutions that really need other decision makers to take action. So thank you very much. And I think we have time for a break.